All right, hi everyone, and welcome to our webinar on low-level laser therapy and its role in balance and posture control. My name is Tom Garrity. I'm an exercise physiologist and laser user myself, and I'll be your host for today. So first off, I'd just like to say thank you so much, guys, for joining us today. Low-level laser is a very exciting and rapidly advancing area, especially when we consider these alarming stats around falls in older adults and the issues around balance itself. It's great to learn about a new approach like this as it can make, such a huge difference for your patients. So today's session, we're going to be diving deep into some of the key mechanisms behind low-level laser therapy and the laser's impact on posture control and falls prevention. Some great applications as well is going to be taught by Brett. He's going to go into that and how it can specifically help in that area. So if you do have any questions during the session, just feel free to type them in the chat because we'll have some time at the end for Q&A. So with that, look, I'm very thrilled to introduce our today's presenter, which is Dr. Brett Jarosz. He's an internationally respected chiropractor, lecturer, and a great expert in the neurorehabilitation and sports area. So he brings a wealth of knowledge in clinical and research experience as well. He's worked with elite athletes across the globe. So without further ado, Dr. Jarosz, we're over to you now.
Appreciate it, Tom. Thanks everyone for attending. As Tom has just mentioned there, sort of two topics tonight. One, we've got understanding low-level laser therapy and understanding photobiomodulation or just light therapy in general. And then the other part, understanding balance and postural control. So there can be attendees on today having a look at some of the people who've signed up. Some people familiar with laser and light therapy, some people who this is their first time getting an introduction because they're interested. And then we've got some people online that are really here because they want to maybe look at the relationships of how we can use both. So for an hour webinar, obviously this topic here tonight is we're going to go pretty at a light speed sort of clip here with getting through the slides. And then I really want to try and hopefully leave it up to you guys to fire some questions away at the end. People that have heard me present before, one of my big drivers of what I try and deliver is we need to understand mechanisms. So from the science, from the evidence, we need to understand how things work. And then if we understand how things work, we can then not have to follow protocols or technique systems. We can think on the fly. You can start to use things off label, a bit like how certain medications get used. They get created for something, then they get used off label because they understand the mechanisms of how they work. No different to when we start to talk about various manual therapies, neurorehabilitation therapies, etc. So this is what we want to try and cover tonight. Now, there are 3 webinars that are available from Rehacare that I've done that has sort of built upon the understanding and the science background of low-level laser therapy and also comparing and contrasting laser, LED, low-level laser versus high-powered lasers. So for those that want to get more detail, we're going to review and hit the high points today, but we can go back and the Rehacare guys can provide you with those 3 webinars that we've previously done. And then we'll also look into, obviously, the overview of balance and postural control. And then we want to start to set some clinical applications. But what you'll start to see is it'll be a bit of a discussion that I'll have with you guys. Well, really, I'm speaking to myself in front of a computer, but have this discussion about if we understand the mechanisms of balance and postural control, with those mechanisms, then we can start to see how we might have to branch off into other areas and assess other systems. And then we can obviously use laser as part of a diagnostic treatment or a treatment in its own right or an integrated treatment as part of obviously helping people with balanced postural control. So that's the focus, obviously, of what we want to try and do here tonight. At the end of it, of course, for those that want to go into this in more depth, we'll be doing a further Rehacare seminar called Enhance, myself and Dr. Kurt Gare from the US, where it'll be a lot more of the hands-on clinical applications over the course of 2 days. So we'll do the best we can to set some scenes here in an hour tonight, and obviously look at mechanisms and neural substrates and physiology. Really, that's the stuff that sort of drives me. So if we look at the scientific mechanisms, important thing of understanding all light therapy. So if we're using any form of light as a therapy, our first law of photobiology says that the light must be absorbed. So in order for any of the light therapy, whether it's a laser, whether it's LED, whether it's these red light rooms that people are now becoming a little bit in fad with and going into these little red light therapy rooms, the light has to be absorbed. So setting that as our first precedence, light must be absorbed. Where it gets absorbed is, this is the interesting part, is that visible light, so the visible light spectrum, we've got some slides on that coming up, but that visible light spectrum, so when we look from blue all the way through to red, the rainbow colors per se, those light that are visible, those visible light photons are the ones that have a photochemical effect, and those lights are absorbed, as we can see in the picture there on the right, within these complexes, within the electron transport chain of the mitochondria. So the one that's been studied the most has been around since the 60s with red light. And so cytochrome C oxidase, or sometimes referred to as COX or CCO, that is the absorber of red light. Okay, so we've got to absorb the light for it to be able to have a therapeutic effect. So when we look at low-level laser therapy, and low-level laser therapy is sometimes referred to as class 2 laser or cold laser. So low-level laser therapy is our visible light, the light that we can see. So we're not talking about necessarily our infrared. Sometimes there can be a little bit of a crossover here, but when we're talking about low-level laser therapy, we're talking about the visible light. Most people are familiar with red, but really today we're going to start to also bring in the blue, violet, and the green colors. And what we know is visible light from low-level laser therapy inevitably involves the mitochondria. So it's affecting the mitochondria. And if you can see in the second point there in the slide, absorption of monochromatic visible light. And this is where it starts to become key. So we've said it, you've got to absorb light. Now, how do we enhance absorption? Absorption is enhanced by having one monochromatic, one color. So if we look at red, and let's just say 635 nanometers is red light, say 405 nanometers is violet, around the 530 nanometer mark is green. So if I can get that one frequency, that one wavelength, I should better say, so that one wavelength, one color, if I can have that one color pointed in one direction, aka a laser, so obviously seeing there with that on my forehead, so if we can have the one color in a beam, that's going to enhance absorption. So when you start to then look at the difference with a laser and LED, LED, of course, is like we think about the LEDs in the room, and they're broad. And as a result of those LEDs being broad, it means the light is coming down on all different angles, and it's obviously white light, so it's not the one color. And because it's not being directed in the same direction, it decreases absorption. Now, the next thing with LEDs is a known issue is just having hair. Now, obviously, I've got an advantage without the hair here, but around the rest of the body, face, etc., LED light is going to bounce off of hair. So you're going to get scatter is the word we would use, whereas we need absorption. So if you look at a lot of the LED therapies, they're going to be telling you that you need to get this closer to the skin and attach it and have it basically resting or wrapped onto the skin. So hence these head-based LED devices or these LED wraps to try and enhance the absorption. Okay, so enhancing absorption is key for visible light to have a therapeutic effect. A single wavelength pointed in the one direction is what's going to enhance the absorption of visible light. And when you can get that in absorption of that visible light, we see increased proton electrochemical potential, more ATP synthesis, increased RNA and protein synthesis, increases in oxygen consumption, membrane potential, enhanced synthesis of NADH and ATP. And this process, of course, is occurring through those complexes 1, 2, 3, 4 of the electron transport chain within the mitochondria. So when we look at that picture there on the left, just breaking that complexity of the mitochondria down, is if we look at complexes 1 and 2 there, we can see that the violet, purple, those complexes there, they are the ones that are absorbing the blue violet light. And so the complexes there have got like a flavin dinucleotide, like we talked about with complex 4 before, the red, which is cytochrome C oxidase. Cytochrome C oxidase is a red light absorbing substance, whereas those flavin molecules, flavin literally translates to blue light absorbing. Complex 1 and 2 there in the mitochondria are what are absorbing our violet and blue light. Complex 3 there is the green, and then complex 4 is the red. So to enhance the effects of visible light on the mitochondria, we actually need to have all 3 colors. Now, when we start to then get into, well, which one's most important, that'll come into play here in a second. So the electron transport chain creates the electrochemical gradient that leads to the creation of ATP in the system we know as oxidative phosphorylation. It occurs in the mitochondria in both cellular respiration and photosynthesis. The electron flow starts at complexes 1, 2, 3, 4, and then makes ATP once it reaches complex 5, known as ATP synthase. And as we said before, low-level laser therapy targets complexes 1, 2, 3, 4, depending on the color of light. So when we start to look at these studies, and I want to break down, if we come back to that slide, sorry. When we start to look at some of the mechanisms, and I'll just touch on it now. If we go back to chemistry, and you may have remembered when we were learning how to make hydrogen and oxygen come together to form H2O. And remember, we had our little rings and we had the electrons, and you'd have one orbit that had 2 electrons, and then you had another orbit that would have, 2 or 4 or 6, etc. And you would get these together and you would go through this process of how do you do the chemical equation to create H2O. Well, those electrons that are on the orbits, in order for those electrons to jump orbits so that we can get those chemical reactions, visible light has energy within it that is able to excite those electrons and make them jump the orbits. Set that scene, we'll come back to that. So when we look at experiments and clinical studies, they've all tended to indicate that low-level laser delivered at low doses produce a better result when compared to the same light delivered at high doses. So again, when we start to look at the research and then we start to look at, say, some of the marketing strategies that are out there or some of the information that's portrayed, and so we start to look at this idea of going into like the class 3, class 4 lasers, the high-powered lasers. So high-powered, high doses, it doesn't do anything to change the wavelength. So the wavelength is the wavelength. So if you've got a red light, making it high-powered is just throwing more of it at the person at one time. And so when we look at the research, it actually shows that that isn't as effective. And the big push is decrease your treatment time. Well, in terms of light having a therapy, having low doses over a longer period of time actually works. Now, this is a bad analogy, but it's a good analogy too. If you went over to someone's house and someone had like some beef or pork spare ribs, would you rather them put them in the microwave and cook them for you, or would you rather them put them on the smoker for you for 8 hours? And most people are going to go, I'm going to go with the smoker. So that energy applied over in a low dose over a longer period of time is on a smoker as the same way as light works. If we can apply light in low doses over a longer period of time, that works better than putting light onto someone in high doses. And where it comes down to this high versus low doses is this biphasic dose response in low-level laser therapy. So when we look at the picture on the right, we're starting to see that red curve that goes up and then ended up coming back down. So it suggests that if we have insufficient energy, so if you look there on that red line at the bottom that's sort of saying, less than that 1 joule per centimeter squared, if there's not sufficient enough energy, there won't be a response. But if we apply more energy, we can then get a threshold to be crossed, and then we start to get stimulation. Now, I don't know if you can see my cursor here. I hope you can. But on this, we've got this red line here across the bottom, basically showing not much stuff happening here. And then we get enough energy that we start to get biostimulation, and that red line starts to go up. But then if we keep applying too much energy, then the stimulation starts to disappear and we start to get bioinhibition instead. And we can start to see as we start getting past this 10 joules per centimeter squared is where we start to see this bioinhibition starting to take place. So when we look at this dosage aspect, one of the simple things to remember is if you think of wattage of a laser, so when you look at the wattage, anything that's over 500 milliwatts is considered a class 3 or class 4 laser. A class 3 or class 4 laser, well, the classes are occurred by the potential damage to your skin and eyes. The higher the class of laser, the more potential for burning your skin, damaging your eyes because they're high powered. But in terms of this biphasic dose response, the next layer is when we look at wattage. Let's keep it simple. If you had a laser that was 1 watt, 1 watt equals 1 joule per second. So if you have a 50-watt laser, that is 50 joules per second. So then if we just look at that graph to polarize this, 50 joules per centimeter squared, that means if you put that laser on someone for a second in 1 centimeter, you've already exceeded the biphasic dose response and potentially put people into bioinhibition and detrimental effects, which is what we're about to show you on this next slide. So when we look at biostimulation, that's been reported in the literature with doses from as low as 0.001 joules per centimeter squared to 10 joules per centimeter squared. In general, if we see red or near infrared as low as 3 or 5 joules per centimeter squared will be beneficial in vivo, but at large doses of 50 or 100 joules will lose the beneficial effect and may even become detrimental. And so this Arndt-Schultz law, or the other word that we know of in more common terminology would be hormesis. So the idea of I go and do weights to stress the system to create tears in muscles, little micro tears, so those muscles adapt. Forget about the neurological responses and hormones, etc. Just the muscle alone, I've got to stress that muscle to be able to create the tears. And if I do it enough at the right dosage, enough stimulus, then that muscle will adapt in a positive way by stimulating it. But if I push too much weight, too hard, we know I can then tear that muscle and that becomes a strain. So there's that detrimental effect. The same with light, the same with medications, the same with supplements. Okay, it's all in this idea of hormesis. So that's what we're talking about here. So general rule that I want everyone to take away with this is 10 joules per centimeter squared. All right, if we keep ourselves 10 joules or less, that is really what we're sort of aiming for when it comes to low-level laser. So the goal would be if we can keep light on someone, low doses for long periods of time and keep it below that 10 joules per centimeter squared, that is going to give us the greater probability of having light having a positive effect. Again, how do I enhance that even more? If I've got monochromatic pointed in one direction, so obviously laser, collimated beam versus an LED, which obviously creates more scatter, which means I've got less absorption. So this one here comes up a bit, and I thought I'd put this in the slides for everyone. I've had a couple of people ask me about how do you do this complexity of the formulas, but it's just a math equation here. So if we look at this here, and if we had this laser being held for someone at 10, so my hand is 10 centimeters wide for people. So if I had that laser just there, 10 centimeters with this laser, we've got a beam that's approximately 0.1 of centimeter wide, and it's about 15.24 centimeters long. So that's the basic measurements of how that beam would come out. So there's your math. So that's a 1.524 centimeter total line generated beam in areas of centimeters. The diode on this laser is 7.5 milliwatts or 0.00575 watts. So as we said before, 1 watt equals 1 joule per second. So if we get the watts and times it by 60 seconds, that gives us 0.45 joules per minute. And then because this has got a 50% duty cycle, so it's on, off, on, off, on, off, that technically means it's half of that. So it's 0.225 joules per minute. And then because we've got our now joules per minute, and then we take that number, and then we've got, there's the beam. Again, if this was at 10 centimeters away from me, so 10 centimeters away from my head there, 1.524 centimeter line beam there. Obviously divide the joules per minute by that spacing. There's my 0.14 joules per centimeter squared per minute. So therefore, if I put this EVRL or the GVL, so EVRL is the Erconia, the brand, violet red, which is what this one is the old model. Sorry, my two newer models are in clinic being used by my associate at the moment. So the violet red and then the GVL, which is the green violet. If you just held that there, what we call point and shoot, and you do not move it. So if you did that for 10 minutes, that means you would have 1.4 joules per centimeter squared delivered during a 10-minute treatment. So that slide there for people, that'll be one for people to keep if you've got your own laser already. And obviously the wattage is different, and obviously the beam that's generated is different. Then obviously the calculation that you're going to have to do, just plug the numbers into where I've put the numbers for the handheld from Erconia. Just plug them in. You'll figure out obviously what the joules per centimeter squared are, figure out what your joules per centimeter squared per minute is, so you can start to figure out where your dosage is. General rule is we're trying to keep it under 10 joules per centimeter squared is our goal. Now, this part here is where we get into like the physics, the biochemistry, quantum physics, really. So the energy, so when we look at the back and we start to see the things here on the back that start to give you like this wattage. So I'm just trying to find it on the bottom here of where the actual wattage is, which is listed in here. You guys aren't going to be able to see that on there. So the wattage is power, okay? Wattage, power equals joules per second, all right? The watts, how many watts, that equals joules per second. But the energy is dependent upon the wavelength, the color of the light. Power wattage, energy is the wavelength, energy is the color of the light. So when you look at that picture on the right of your screen there, down the bottom, you can see your photon energy in electron volts. So we can see there 3.1 electron volts. That's the energy within violet. So violet is the most energetic of the wavelengths that you can see in the visible light spectrum, the colors that you can see. Violet has the most energy. And then we think about it, what happens after violet? Violet, next step up, more energy, ultraviolet, but we can't see that. Okay, so the visible light spectrum, violet, Drop down to green, we're at about 2.4 electron volts. Red, we're at 1.9. So that importance is photochemistry. That mitochondrial effect in complexes 1, 2, 3, 4 from the earlier slides, that is dependent upon electron volts. It's dependent upon the color of the light, not on power, not on what the wattage of the device says. It's about the color of the light and the energy that's within the color of the light. So the photon energy. So violet photons have more energy than green photons, that have more energy than red, that have more energy than near infrared, which obviously we can see down the far right of that picture. Now, this point here is a really important point. A minimum photon energy of 1.7 electron volts is required to cause electrons to jump to higher orbits. So that was going back to our little circle, going back to your chemistry where you had, your 2 electrons, and the next shell around it, you had, your 2 or 4 electrons. In order to make those electrons jump to get that chemical reaction, photochemical reaction, we need at least 1.7 electron volts, which is red. So it's visible red light is what's required to be able to get those electron jumps. Now, what becomes really interesting is that when we use a higher energetic wavelength, i.e. violet or green, that what happens with that is those electrons have the ability to jump 3 orbits. So going from 1 orbit, they can jump up 3 orbits because they got higher energy. And then as they come down the orbits, they're releasing further electrical photochemical energy. And so as a result, violet also then all of a sudden, as it's coming back down to its resting potential, violet, when it jumps up with its electron volts, as it drops back down, it releases green, and as it drops back down, it releases red. So when we start to look at it, the higher energetic colors having this photochemical effect, this quantum physics effect, again, that's the visible light and going towards the violet end of the spectrum that has the most energy. So again, when we look at that, complex 1 and 2 of the electron transport chain within the mitochondria, they absorb violet, which then if we see yourself following the actual picture across, then we go to the green, then we go to the red, and then into ATP synthase. So when we look at further mitochondrial diseases, and we go into these in the day's seminars, etc., we're starting to see that certain neurological conditions, certain muscular conditions, cardiac conditions, we are starting to see that there are relationships with issues of specific complexes. So as an example, using over-the-counter medications like NSAIDs or statins, we're starting to see that like NSAIDs have an effect on complexes 1 and 4. So then the catch is if you've only got red as a color of light therapy, whatever your choice is, laser or LED, if you've only got red, then we're missing complex 1 there, which has also been affected by using medication. So there's a website now called Mitotox, which is a website that you can have a look at all the different drugs, medications that are out there and the influences they have on your mitochondria. So which drugs are toxic to your mitochondria. And we can start to see the impacts of just simple over-the-counter medications on mitochondrial health. And so visible light is a way to enhance the health and function of the mitochondria. So the key concept is complex 1 is considered to be a rate-limiting reaction. If there is dysfunction here, it will affect all the downstream complexes. You can only impact complexes 1 and 2 with a violet wavelength, as it is the only one with the sufficient electron volts, the energy, to trigger the necessary electron jump. So violet, as we said, the most energetic of the wavelength, and that's the one that's absorbed in complexes 1 and 2, and complexes 1 and 2 are the ones that are required, part of your electron transport chain within your mitochondria, and we need violet to start to help that process from the start. So we look at this particular article, quotes from this one: wavelength is the most important determinant in how light affects tissue. So the color is the most important determinant in how light affects tissue. Wavelength determines the quality of type of interaction between the laser and the tissue. So again, the color of the light. When we look at this simple little table here, visible light versus infrared, now we start to get into our understandings of photochemical versus photothermal effects of light therapy. So visible light, the light that you can see, violet through to red, that visible light is strongly absorbed because it does that electron jumping that we talked about because of the electron volts. Because visible light has a lot of photonic energy. It has a higher electron volts above the 1.7. That causes the electrons to jump. So it creates these photochemical reactions within your cells, in particular within your mitochondria. Infrared light is different. And what happens is infrared light, a bit like thinking about what you do with a microwave. Microwave, you put your food in the microwave, and the microwave causes vibrations and oscillations. And because it's causing these vibrations and oscillations, it has a physical effect. And that physical effect is that it creates heating. Just think about infrared saunas. Okay? So the infrared wavelength is absorbed by water, and it causes this oscillation, vibration of the water molecules, and that creates that heating effect. So the mechanism's just here for you. So water doesn't absorb visible light. Okay, so water doesn't absorb the visible light. The visible light spectrum's too energetic, as we said, the 1.7 electron volts. So infrared light spectrum, though, has strong absorptions from the vibrations of the water molecule, and the result of infrared absorption is heating of the tissue since it increases molecular vibrational activity. So it has a photothermal effect. So infrared, mechanical effect, photothermal effect, hence that's why those types of lasers, we move them on people because it creates a heating effect. If we kept it on the one spot, obviously we've got a chance of burning people, especially then if we're dealing with a class 3 or class 4 laser, because then I'm throwing more of that infrared at people, which then increases that chance because I've got greater joules per centimeter squared, greater amount of infrared being thrown at someone, greater oscillations, vibrations, photothermal effects. So infrared, photothermal; visible light, photochemical. And now, obviously, when we start to think about, well, how's that affecting us when we put it on the human skin? Well, our skin is considered 95% water. So when you shine infrared light on the skin, it's being absorbed in the dermis, and the result of that is our topical heating. So when we look at photochemistry, visible and infrared affect biostimulation in different ways. And again, just the evidence just to support what we just discussed. Visible light elicits photochemical changes, whilst infrared can only produce the physical changes. So visible light, photochemical; infrared, vibration, oscillation, photothermal. Although visible light can produce photochemistry, infrared radiations only produce the molecular rotations and vibrations. And then here's our quantum discussion. So considering the low quantum energy per photon for the 785 to 905 range, that's infrared range. So when we're talking about like that 800 up, they're your infrared wavelengths. Those only give you like 1.5 electron volts. Remember, we said 1.7 electron volts is what's required to induce the photochemical effect, and that's what they're talking about there. So that does not induce the photochemical effect, as the minimum quantum energy is in the order of 1.7. So one of the interesting parts that comes up when a lot of people, this was just a quick PubMed search that I did. You can see the search terms that I use there: low-level laser placebo-controlled. And that is how many research articles showed up, 712, versus class 4 laser placebo-controlled, there's 23. And so there's a lot of people where they go, you know, there's no evidence for low-level laser. There you go. There's just a quick PubMed search for that because there is a big argument that goes on between low-level laser versus class 4, but we want to understand how they're different. And you can see here, not only is it different, there's obviously a difference with the amount of research that's also been done between those different types of lasers. So just obviously my background I like Star Wars. So to be a laser Jedi Master in Impact Complexes 1, 2, 3, 4, you will need to have all three colors in a true collimated to enhance absorption. So when we look at laser compared to LED, in any trial, when you look at laser versus LED, LED works, but because it's broad, it's not collimated, you don't get as much absorption. So the efficiency or the efficacy of it's less. In general, when you compare it to a laser, if you gave a 635 nanometer, so red laser, true collimated laser, and a 635 nanometer LED, and you applied it for the same dosage, the same amount of time, same dosage, same person, same area, the LED at best is going to give you about 30% of what the laser does. But what gets interesting is when you start to do some of these controlled trials between laser and LED, where LED is the control, what you'll start to see is over time, both of them are getting better. This would be the laser decreasing symptoms, whatever it may be. LED is also decreasing, but it's more like that. And then what happens is when you stop using the two, laser continue to get physiological changes because of obviously the effects on the mitochondria, more absorption, more profound. We start to see when you stop using them that the LED group start to regress. I've got slides showing that in the other Rehacare webinars. So a quick review there on laser, but if we start to look at balance and postural control, this is a massive topic because if I was going to say one thing to everyone here, balance is the most sensitive test you can do for anyone because the time of day, when you ate, how much food you got in your system, how hydrated you are, noise in the room, temperature of the room, how much your heart beats, all of that influences balance. So therefore, we need to understand sort of mechanisms of balance and how we can assess balance in the best way possible. And this applies to polarizer as it relates to our older adults. So a third to a half of the older adult population will experience a fall at least once a year. A third to half. And older adult falls will remain the #1 cause of disability, hospitalisation, and injury-related death for decades to come. Older adult falls have been linked to an increased occurrence of future falls and have been shown to underlie a fear of falling that dramatically reduces the quality of life. There's also a study, I should have put it in here, sorry, but if you're over the age of 70 and you have a fall, there's a 50% chance that you'll die within the next 12 months. So falls prevention becomes a very big thing for us to serve our communities and serve the people around us, loved ones, as well as the people attending your clinics. So let's understand postural control first. So postural control is crucial for obviously most tasks of daily living. The minute you wake up in the morning and you're upright, simple rule, you're dealing with gravity. I've got to be upright and deal with gravity. So posture's two parts. It's orientation and balance. And there's continual adjustment, which uses different systems. All right. So there's no balance system. You've got multiple systems that are combining information to help you balance. But when we say the word sort of posture, I've got orientation and I've got balance. I use my body, somatosensory, so the joints, the skin, muscles. I use my inner ears, my vestibular system, and I use my vision, and I put that information together to give me a picture about the position and velocity of body in space and to generate and update motor commands that maintain my balance and orientation. So postural equilibrium, or balance is the general word we use, involves active resistance to external forces acting on the body. The #1 thing, of course, is gravity. So balance Active resistance against gravity. And then postural orientation is the positioning of the body segments with respect to each other and to the environment. So depending on a particular task or behavior, body segments may be aligned with respect to gravitational vertical, visual vertical, or to the support surface. And this support surface one's going to be an important one for us to understand in a sec. So let's, again, overview here and understand these three systems: somatosensory system, vestibular system, visual system, all contribute to postural control for balance and orientation with differing degrees of influence as our environment changes. So depending what you're doing, you will rely on different systems more to help you balance. So let's understand that. If you're on a hard, flat surface, most of life, walking around on hard concrete floors, if you're standing on a firm surface that's flat, we normally rely on our body. 70% of the information's coming from the somatosensory information, 20% on your vestibular system, 10% on vision. So your ability to be upright, deal with gravity on a hard, flat surface, 70% from your body. Now, when it comes from your body, neck, ankles, feet, hips, in that order is where you get most of the information from. Of course, you use legs and you use spinal muscles, etc. But in terms of the regions, neck, ankles, feet, hips are our big three areas of it from our body. 20% vestibular, 10% on vision. However, when you go and stand on a surface that's unstable, now I want to polarize this to sink this in. Wobble boards, Duradiscs, foam pads. Let's think the number one injury in all sports isn't lateral ankle sprain. Is the most common injury when we look at all sports. And of course, there's going to be certain sports where other injuries are more common. But if we just look at all the sports across the world, the most common injury that's going to show up after we account for everything is going to be lateral ankle sprain. And one of the exercises that are given to lateral ankle sprain injuries are wobble board, Duradisc, foam pad, balance exercises, but done on an unstable surface. I want us to understand why we want to use it and why that might be one of the stupidest exercises you can give. Because when you stand on an unstable surface, your nervous system re-weights, and you now rely on your vestibular system for 70% of the information, vision 20%, and body 10%. So let's go back to our ankle sprain clinically. So someone sprains their ankle. Which system is the system that got damaged with your ankle? Well, you overstretched ligaments, you overstretched muscle tendons, joint capsules. You damaged the somatosensory system, proprioception, somatosensory. So why do you want to put someone on an unstable surface and make their vestibular system compensate for that? I was going to do my PhD on this because one of the questions I posed is this why recurrent chronic ankle instability is such a problem with ankle sprains? Because our rehab that we're doing, we don't understand actually what we're doing. So if we understand mechanisms here, and immediately with that, you've got an understanding of which system I may or may not use more or less of in order to be able just to balance upright under gravity. Hard, flat surface, I'm primarily using my body. Unstable surface, where my feet and ankles are moving. Again, think foam pads, standing on pillows, standing on a Duradisc wobble board. That's going to make you rely on your vestibular system more. So let's have a look at that picture there. So the reason that works is look at the picture on the left, stick man there, and you can see the center of mass, the asterisks, right in front of like that L2, L3 area. When you're leaning forward from your ankles on a hard, flat surface, so there's the hard, flat surface, there's the ankles. Now, center of mass obviously is up here. If he leans forward, he or she leans forward there, the ankles are moving forward, center of mass moves forward. your ankles, your calves, those musculature are letting you know that you moved forward. So the somatosensory system let you know that that center of mass moved forward. And that's what your body's measuring, the center of mass. Now you look at picture B there, and they're on a duradisc and unstable surface. Well, those ankles are moving there now. So you're getting that somatosensory information, but your center of mass isn't changing. It's the ankles. So now your brain needs to rely on what your ears are telling you about. Is your head moving? Is the head moving under gravity? So I've got to rely on that vestibular system to give me that information. The picture on the graph on the right is just showing you that. The more that that platform moves, the more unstable it becomes, the more vestibular it becomes. Obviously, the more stable it is, the more somatosensory it is. But takeaway, hard, flat surface is primarily somatosensory, 70%, whereas I'm on an unstable surface, primary system, 70% is going to be vestibular. So then let's add this now clinically and understanding this, that these sort of three areas, again, massive topic to try and cover in like a webinar here where we're doing laser and postural control. But when I'm standing, and let's just say, let's keep it simple, Romberg. So we get someone to stand with their feet together and then we have them close their eyes. When you do that, obviously we're observing and you're getting ready to catch someone to see if they fall. But understand that if you see someone just swaying and that sway continues to happen to the right, or they sway and they fall to the right, you are going to sway and or fall to the side of the deficit classically. And the deficit is going to be if I sway to the right, you're immediately going to start to think right vestibular deficit, hypofunction, decrease, maybe pathology, down. It might be the cerebellum on that right side, hypofunction, dysfunction, decrease, down, pathology, whatever it may be, on that right, ipsilateral brainstem. So if I sway, so when we say ipsilateral brainstem, the central vestibular projections into that ipsilateral brainstem, into that pontomedullary area. So we need to understand our mechanisms here now. So immediately just with that, you've seen someone stand and you do a Romberg and they sway, and from your undergraduate training, you were taught posterior columns, joint position sense, etc., right? Well, yeah, maybe. But now we've also got to go up, and that idea of if I'm swaying to one side, that could be vestibular, that could be cerebellum, that could be ipsilateral brainstem. How are you going to differentiate it? So this is where looking at these tests, and I've got to tease out, well, now I've got to look at vestibular testing. Now I've got to look at cerebellar testing. Now I've got to look at somatosensory testing. Okay, so that takeaway now, when you see someone sway to one side, ipsilateral vestibular, ipsilateral cerebellar, ipsilateral brainstem. So our clinical applications, therefore, how could we use laser as part of your therapeutic approach to helping balance postural control? Well, first of all, we've got to tease out which system we may be wanting to try to influence. So a classic simple one to use, balance error scoring system. So this particular testing you can see on the left, it's done 3 different stances. So feet together, then your non-dominant leg is going to be the stance leg on single leg stance. So when you say non-dominant leg, you ask the person, which foot would you kick a ball with? And if they say I'd kick the ball with my right foot, you're going to have them stand on their left, or vice versa. So in position B, left leg's non-dominant. Position C, the non-dominant leg is the rear foot in that tandem stance. So you can see in C, left foot's back. Every position, as you can see, is the same. We have hands on the hips. We close our eyes. So we do this on a hard, flat surface, and then we do it on the foam. Same stances. And then what you're doing is you're asking the person to stand with their eyes closed, hands on their hips, in each stance for 20 seconds. And then you are counting how many errors they make. You can see the errors are listed there on that scorecard. So if you take your hands off the hips, that's one error. If they open their eyes, that's one error. If you step, stumble, or fall out of position, that's an error. Now, if you did 2 of them at once, it's just 1 error. Okay? You don't give 2 errors if they happen at the same time, just 1 error. So we can see your different scoring system. Now, what's the problem with that? It's left up to subjective interpretation, but it's a start. Now we look at that and you go, well, the top row is going to be assessing a little bit more of the somatosensory system. But when you get to test C on that picture in that tandem, that starts to bring in a little bit of that vestibular system. And then when we get you down into D, E, and F, that's, of course, bringing you more into that vestibular system because you're on foam and you're on an unstable surface. Next part of it is when you stand on that single leg, for a reference point for everyone, the problem with single leg stance is everyone learns to wobble better. There is a learning effect with single leg stance. Single leg stance really shouldn't be part of your weighting of your balance. You're really not going to put as much weight onto single leg stance balance as you would the other ones when you're looking at it from a postural control balance assessment. Now I'm going to pick on the balance error scoring system here now. So there's your normative data that's been pulled up. So I've got that there for your reference. So if you want to use the balance error scoring system, if you've never done any sort of balance tests outside of Romberg's, here's how we can obviously score. And we've got our normative data for you to have a comparison to baseline. Now let's look at the modified balance error scoring system, because this is what's used now in the concussion world. So this is part of your SCAT-6 and SCOT-6, how we assess concussion. So the picture on the bottom right, you can see it has the modified BESS. The modified BESS is just doing the best testing on the floor, no foam. Now, in concussion, you can see on the top left, the quote, errors have been observed on the single and tandem stances with 4 errors on the total MBES. So that means double leg stance, single leg stance, tandem. So in those 3 stances, so 60 seconds of testing, 20 seconds for feet together, 20 seconds single leg, 20 seconds tandem. So in a sporting population, if you saw 4 errors, so their hands came off their hips 4 times, or they opened their eyes 4 times, whatever it was, they consider that the ideal cut point to distinguish concussed from non-concussed athletes. Here's the interesting part. If I do this in a seminar and I get people doing that, we see way more than 4 errors. So we go, already there's issues. Now, the next bit, foam conditions of the full BESS provided better discrimination between concussed and control participants. However, in the SCAT-6 and the SCOT-6, you don't have to do the foam. Now, let's look at this. Are you going to have a foam pad sitting on the side of a rugby field or a football field or wherever you may be to do this? That's the next part, right? So they remove the foam from a convenience point of view because they're on the sideline trying to determine whether or not I'm diagnosing a concussion or removing someone from the field of play. But from our point of view, if we want to then do things to help people, we need to know which system is involved, and the systems that are involved, well, we need to differentiate. Is it a vestibular problem? And if we need to figure that out, well, one of the things we need to do is to put people onto foam. The next part on the bottom says the magnitude of sway. Now, this is a bit of the problem, is like, how are you going to determine whether or not someone moving this and forward and back, how do you differentiate the magnitude of sway just when you're looking at the balance error scoring system? Because you're just calculating errors. We can't actually measure the postural sway. Now, I gave you that tip before. You can observe it. And if you see someone's constantly going one way, you've immediately now got a clue that you want to look at that ipsilateral vestibular cerebellar brainstem. But how are we going to measure that postural sway? I love this quote In the era of evidence-based practice, objective measures should be a norm in the clinical care for patients with concussive and other neurological injuries from the sidelines to hospitals and neuro rehab clinics. Indeed, the addition of validated measures, love this, will eliminate eyeball-metrics. The fact that he put that in writing into a research article, what? Just a great word. Eyeball-metrics, trial and error, and guesswork from the decision process. These will help make clinically meaningful interpretations and augment the standard of care delivery process. Overall, providing significant objective evidence will only eliminate conjecture, and clinicians can successfully integrate these into decision-making. So what are we talking about here? If we're going to assess balance, what we're saying is we really need to be using force plates. Okay, they are the gold standard for balance assessment, for objective and sensitive means of measuring body sway control. Force plates measure balance by calculating an individual's center of pressure. So obviously the center of pressure is obviously the pressure going through your feet onto the force plate. Metrics based on center of pressure signal are a proxy for the amount of body sway control necessary to maintain balance, whereby an increase in the center of pressure metric magnitude is thought to represent poorer regulated center of mass and highly likelihood of falling. Unfortunately, force plate balance testing is not widespread due to high costs, e.g. $10,000 to $150,000, and a lack of portability for feasibility testing balance at multiple sites. Well, that's not quite true nowadays, because we actually, I think one of the people that may be online today on this webinar is actually a distributor of a force plate that I actually use in clinic. This one here. So balance tracking systems. So some of the research, so the force plate that they use has been shown to have almost perfect agreement between the balance plate and the laboratory grade force plate during center of pressure assessment. The results suggest that the balance track can serve as an effective low-cost solution for objective balance testing in the lab or clinic. And the balance track is an effective means of identifying older adults with elevated postural sway who are likely to benefit from a GeriFit training program to mitigate fall risk. So force plates, as we said, gold standard. Balance track is relatively inexpensive, approximately 5,500 Australian, and therefore it's got opportunity here for widespread use. As you can see, the handle on the force plate, that thing travels with me when I go to my sporting events and I'm working on the sidelines. Put that, I just wrap it in bubble wrap, put the foam on top of it, and I put that in a suitcase and I travel with that. And that thing I have had now for, 7 or 8 years. That has, and I've had them all. I've had the $30,000 force plates, $15,000 force plates, and that's the one that I use personally in clinic myself. No disclosures. That's just one. I was involved with the beta testing, by the way, for that. So that's the disclosure, but I don't make any money from anything to do with balance track. So it's just, that is the product that I use. It is the most affordable product, and it's the one product that actually has the greatest normative database for assessing different postural sway parameters across entire gender and age groups. So it comes with the balance plate, foam pad, but have a look into it more for those that are interested, because if we're going to assess balance, we really need to be using a force plate. All right. The balance error scoring system is just riddled with issues. If we're going to assess balance, we need to use force plate. So let's look at what we can do now. We've said, if I assess balance, I now know I've got visual, I've got vestibular, I've got somatosensory. If I've got nothing and I've just got a Romberg test or a balance error scoring system, and you're looking at someone that's having, they're talking about they've had falls, you've had a look at their assessments and you're seeing a sway, one of the simple things that you can do without us going any further is you have them stand in a position that challenges their balance. So if it's feet together, eyes closed, as long as they're safe, but challenge their balance in the safest way, but the most challenged way that's safe for them. And then all you do is grab the laser. So if they're swaying to the right, so they're swaying this way, basically laser them on the right side as if you're trying to push them that way with the laser. Don't do any other therapy. Just purely laser them. So if they're swaying forward, laser them at the front. If they're swaying backwards, laser them at the back. If they're swaying to the left, laser them there. If they're swaying this way, laser them there. So I've just listed that. If the patient sways backwards, laser that occiput cerebellar region, et cetera, et cetera. Don't do anything else and then retest their balance. Now, I'll talk to you about how we do point and shoot, et cetera. And the reason for that is you want to find out whether or not that laser did anything, one from a patient point of view, but one from your point of view. Because if it's going to have an impact, it's going to have an impact quick. The beautiful thing with lasers, you'll see these things happen quickly. So your point and shoot protocol, when I do brain-based work, they are the settings that I use. So it's 1, 10, 40, 60. These are brain frequencies that come from EEG studies, sleep studies, et cetera, et cetera. So we refer to that as the master brain frequency that gets put into every EVRL and GVL laser. And so that's what the frequencies are. So it means that when you look at this one here, just so you guys can see this, you will see the violet on my forehead firing 1 hertz there, now 10 hertz. 1 hertz now, 10 hertz now. The red you're not really going to be able to see moving because that's going at 40, 60, which is too fast for your eyes to be able to see. Laser distance about 10 centimeters, like we talked about before, like my hands width away is sort of that sweet spot. But if you wanted to, the beauty of this, not that you're really going to be able to see this too much, but if I've got my forearm, I could move that laser to cover my whole forearm there. Okay. So I could use the laser beam as a guide as well. We want the laser to be perpendicular in orientation because what are we trying to do? We're trying to enhance the best absorption, 5 to 10-minute treatment duration, minimum treatment duration of 2 minutes. That already, if they're going on the right, 2 minutes here. Backwards, 2 minutes here, absolute minimum. That's your point and shoot type protocol. But if we're trying to then bias vestibular system, well, we also then need to figure out, is the vestibular system involved? So if we look at balance and you put them on the foam and that's when their balance starts to get worse and you're going, this may be a vestibular problem, well, you might need to now look at VOR, head impulse testing, etc., to get an idea of this person's vestibular system. And if that was the case, we can then use the same laser settings, but what you would do is if I saw them sway to the right vestibular system, if I did a right VOR, and when they turned their head to the right, their eyes went with their head and then came back. So a catch-up saccade, they're good here. Then they do that. Or a head impulse test, they do that. You've got more clues there now that might be that right vestibular system. So now maybe I'm going to laser that vestibular system. I'm going to laser that cerebellum, and I'm going to laser the opposite parietal lobe. And I might be doing VOR, vestibular exercises, while I'm lasering them. I might have them standing on unstable surfaces while I'm lasering those areas. So I'm getting that vestibular system being activated while I'm getting energy, light energy, into those systems while we're stimulating that system from a physical mechanism with rehab, and then we're helping give it a shot of energy from that laser. Somatosensory. So you saw me maybe falling to the right. You've gone and done the vestibular testing and you've gone, no, when they were on the foam, they weren't swaying, but when they were standing on the hard, flat surface is when we saw it. You did all your vestibular testing. That looked good, but maybe you went and did light touch. You did joint position sense. You did 2-point discrimination. You did other somatosensory type tests. And of course, one of the big ones that we're going to be dealing with is what? Diabetes. And so then you start to see these problems with these long fibers to the feet, and they start developing peripheral neuropathies. Chemotherapy, another common one that gets under sort of appreciated. You know, how many people now are going through chemo for cancer? Well, a lot of the chemo agents give peripheral neuropathies. So diabetes, chemotherapy-induced peripheral neuropathies. So if I can't feel my feet somatosensory-wise, right, so I've got to go and check that. Can they have sharp, dull, 2-point discrimination, light touch, hot, cold, etc.? So we check our senses. And again, what do we use? Same type of settings, but we can apply laser to the feet or to the legs along those nerve pathways, go to the nerve root at the spinal cord level, go up to the cerebellum, go to the opposite parietal lobe, and you can then stack that laser with different somatosensory stimulation, percussion massage, vibration massage. Remember, there's a difference between the two. TENS stimulate nerve endings, electromuscle stimulation, taping, mobilization, soft tissue techniques, dry needling, standing on firm surfaces, etc., etc. So stacking, understanding mechanisms. How do I stack the laser with the appropriate mechanisms of what you're trying to address? And then, of course, if it's the visual system, well, how are we going to assess visual stuff? Well, you've got, think about your undergrad stuff that you may have learned, like Snellen charts, doing alternating exophories, like your cover uncover type testing, Brock string testing. But the same thing, lasering occipital lobe, lasering temporal lobe, the Watt pathway, lasering parietal lobe, the Ware pathway, and doing vision therapy while you laser those areas. So, like we said, we can't just talk about balance and just say balance. We've got to be able to also understand how we go and look at those other systems, and then how do we potentially use laser in combination with that specific system being addressed. So then we look at these different neural substrates with that. So I tried to list a few things there. If you go, well, if I've got a somatosensory problem, different somatosensory clinical applications. Your manual therapies are somatosensory, using different types of taping, whether it's rigid, kinesio tape, dynamic tape, two-point discrimination, graphesthesias, moving someone's arms in infinity movements, making them do isometrics, making them do movements with their arms on legs in time to metronomes, getting people doing spinal stabilization exercises. Now, if we put people on unstable surfaces, that starts to bring in more of a vestibular system-based approach too. And then you've got all your vestibular oculomotor therapies for those that are sort of trained in that space already, different types of movements that you can do with head and eyes, different eye exercises. How do you do balance exercises? Do you put them on a firm, flat surface versus an unstable surface? Doing different gait exercises where we get people walking normally, or getting people walking and dual tasking, so they're doing something cognitive while they're doing a gait activity. Again, lots of different mechanisms and lots of different therapies that are out there. But rather than following a protocol, understand the mechanisms, understand the neural substrates that you're trying to address, because your tests let you know which systems that we need to go and address. And then it's a matter of finding which is the most neural substrate directed application for that person that's going to give them the best chance to be able to get the outcome that they're after, as well as that you're after.
That was a wealth of information there. And, you know, I know we only had an hour there up our sleeves, but if you guys are looking to learn even more about all this stuff, we have some very exciting opportunities coming up. And one of the biggest opportunities is our enhanced workshop in Gold Coast, as you can see on the screen, May 24th, May 25th. Both Brett Jarosz and Dr. Gare will be there in person. So write that down in your diaries, because, guys, this is seriously a great chance to really dive deep and learn firsthand from the best in the field. It's a great 2 days. You get hands-on experience, and it is the most advanced workshop you can do in Australia when it comes to low-level laser therapy. You know, I've been to a couple, and, you know, I can say, if you ever do want to attend something that just completely blows your mind with the amount of knowledge you can gain, not just on laser, but also just enhancing patient care, and overall, you can see what Brett goes into. This is something you really need to attend. So, you know, you can find all the details on Rehacare website under upcoming events, but we will also be sending out an email to you guys about the details on that one. So we can't wait to see you guys there. We do have some other upcoming events as well. Brett's also going to be speaking in person at some seminars. They're 1-day events. There's going to be one in Perth. That's on 5th of July, one in New Zealand in Auckland. That's 30th of August.
On that, Tom, we literally just had a question. Do you ever come to New Zealand? Yep, we're coming this year for the first times.
We're also going to be involved in the Sports Chiropractic Symposium. That's going to be the week before the Enhance. So if you guys are around in Gold Coast, that's in Surfers Paradise, we're going to have a booth there. I'll be there, and you can come and talk to us and also get hands-on experience with some of the lasers and see it for yourself. Another one that's coming up is going to be the ACA conference. That's coming up in August, 2nd and 3rd of August. That's at the Pullman on the Park in Victoria. So that's going to be a great one to attend. Overall, guys, thank you so much for attending this webinar, and we look forward to seeing you guys soon at future events.